lectures are going to be by Zoom unless things really mellow out with COVID. I will tape all the lectures and I'll have them up on YouTube so that if you ever want to review the lectures or anything like that, you can. But the state has a requirement that you guys are in class for every class. So it can't be that, you know, you're going to be missing the actual lecture component and planning on watching it on your own. So that's not going to cut it. That's why we wanted everybody to make an actual Zoom account so we could see and do a report on, you know, who's in class for state purposes and stuff like that. Okay, so you actually have to be in class when class is going on. Obviously, if you need to run to the bathroom, you need to do something like that, by all means, just go ahead and do it. And we will, you know, remind me, but we will periodically take a break so you could stretch your legs and everything like that. I also have an online testing program. So at the, you know, either the day after or you know, 2 days after every class, I'll send out a, you know, a brief test that you could do. It's really for both of us. It's for you to know what you need to review, and it's for me to know what kind of job I did with teaching the material and see if there's anything that I need to review with you guys. It's not a test like if you fail it, you're out of the class or anything like that, but it's more just so that we both know where we're at with stuff, and maybe it'll help you to know things that you maybe don't understand that you want to ask questions about and stuff like that. Did everybody get textbooks? Did the textbooks come in yet, David?
The students themselves are required to order them.
Okay.
Right?
So please, you're never going to get through this class without the textbook. My experience in teaching EMT class to a Jewish population is that you prefer to sit and listen to me teach, and you think you're going to get everything that way. The problem is that, you know, there's not enough time to teach every single word in that textbook. We'd be here for years to teach everything. So you do need to read the chapters in the book, okay? And I will look at the schedule and try to put out a kind of a reading list so you know what you should read for when. But there's no way that you can, you know, just listen and get everything you need to get. And you'll see that when you do the exams and stuff like that. So you do have to get a textbook. You do have to try to read it, okay? I know for some of you, it's going to be hard to read it and hard to understand what they're saying, but trust me, even if you read it and don't feel like you 100% understand it, it's going to make sense when we actually do the lecture. So if you can do the reading before we actually have the class, when we teach it in class, what you're reading will make sense to you, even if it doesn't make sense to you at the exact time that you're looking at it, okay? Just trying to think if there's anything else. Oh, so skills, like I said, David and Yankee are going to be coordinating skills. There will be CPR skills this upcoming Sunday, and they set up I sent out a sign-up sheet that they, you know, wanted me to send out to you guys so they know sessions. One of the things that we have to be very, very careful about and very strict about is making sure that the classes are run with the right COVID precautions. And that's going to mean that everybody's going to have to check their temperature, okay, before they come to class and wear a mask. Because the political fallout, if we wind up having an EMT class and it turns out to be a COVID spreading event, will be disastrous. I mean, we'll have to end the class. So we have to be very careful. I know everybody thinks they're immune or, you know, that it's a hoax and everything like that, but we have to be very careful that we do nothing that could cause, you know, there to be a, God forbid, a breakout of COVID, you know, inside of the class that we're doing. So there's zero tolerance as far as that goes. You know, no masks, no, you can't be in class. You have to do your temperature screenings. And obviously, if you don't feel well, don't come to a skill session. We'll figure out a way of making it up with you, you know, at a different time. So if you don't feel well, by all means, you know, stay home. Or if you're around someone who you know was COVID positive, you know, let us know and we'll work out something to, you know, be able to make up the skills. Okay, so before I start with the actual talking about the CPR component, does anybody have any questions about how the class is going to run administratively or anything like that? Skills, lecture, anything? Anybody have any questions that they will want to ask? Okay. So like I said, tomorrow I'll send out my my phone number, and you know, you guys, you can text me or whatever you need to do as far as asking questions and stuff like that. Okay, so we usually start class out with CPR training. I know some of you had it, okay, and that's great. It'll go easier for you. And you know, some of you have it, so don't panic. And if you've never had it before, just make sure that you let the instructors know it's the first time. And, you know, hopefully we'll be able to break you out into groups from people who have done it before and people who haven't done it, so that the people who haven't done it don't feel pressured, you know, by the people who have done it and stuff like that. So basically CPR stands for cardiopulmonary resuscitation. So cardio means heart, pulmonary means lungs. Okay, so you have your first two medical terms. So resuscitation obviously means trying to save someone. So we do CPR on someone who's in a term called cardiac arrest. So cardiac again is heart, and arrest means that the heart has stopped. The heart is no longer pumping. So we're going to do a little very brief review of what the heart is and the anatomy of the heart, so you understand why it is, you know, we have to do what we have to do. So the heart, and this, people who are plumbers actually understand this best. So the heart is basically just a pump, okay? It's a muscle in the middle of your chest that squeezes and pumps blood around. And it has 4 chambers, okay? So if you look over here, the heart has 4 chambers. Let me find one that actually shows you the chambers. Okay, so can you see now where I have the heart with 4 separate chambers in it? Did the screen share change? Somebody nod their head. Yes? David,
it's a little unclear for me.
Why is it unclear? It's blurry?
Yeah. It's only for me or for everyone?
No, it seems like it's blurry.
Yes. No, it is very blurry.
It's blurry. Okay, so let's see. Let me see how we could do this.
No, it looks like your internet is a little bit choppy. The entire screen is blurry.
Well, I'm opening up something new, so let's see. Is it still blurry now?
Yes.
Still blurry?
Yes.
Yes. Very blurry.
Very blurry. Okay. Well, let's give it a second and hopefully it'll catch up with it, because I have 5 bars on my internet, so I don't know why it would be blurry. Okay, so basically, like I said, the heart is a pump in the middle of the chest, and its purpose is to pump blood. So the reason blood is so important is blood, the fluid of blood, is the transport mechanism to get to the body everything the body needs to work. Okay, so at a very basic level, the blood has to contain oxygen, okay, and has to contain sugar. Those are the 2 main things the body needs to do what it needs to do to keep us alive. So the heart pumps the blood contains the oxygen and sugar. Now, I mean, I'm sure most of you can figure out that we've gotten the oxygen into our bloodstream by breathing, right? We open our mouth, bring air into our lungs, and it crosses over into our bloodstream, and that's how its oxygen gets in. And sugar, obviously, most of you know we get by eating. Same thing by digestion in your stomach and your intestine. You draw the sugar out of the food, and it gets into the bloodstream and is transported around. So, you know, hopefully most of us, our heart is beating 60 times a minute, okay, for our entire life, and it pumps blood, and that blood contains what we need. When somebody goes into cardiac arrest, that heart stops pumping, okay? Now, there's many different reasons. We'll talk about the different reasons why it stops pumping, but the long and short is that the minute the heart stops pumping, a person is dead, okay? Now, it doesn't mean they're dead permanently, but every minute that goes by, the organs of your body, your brain, your heart, your lungs, your kidneys, all the different organs of your body, when they're deprived of that oxygen and sugar, they start to be injured, okay? And typically when it goes past 5 to 8 minutes, that damage becomes irreversible, which means you can't reverse it, you can't save them. So that is why the speed in which somebody is resuscitated is very, very important. Now, where's CPR, you know, what we're talking about now, where does that come in? So all CPR does is circulates blood. You're compressing on someone's chest, okay, and trying to squeeze their heart between their chest and their backbone, okay? And by doing that, you're trying to pump blood through the body. So you're basically taking the place of what the heart would do normally because it's injured and it's not doing it, okay? Now, CPR alone is not going to bring somebody out of cardiac arrest, okay? It requires other things. The most common reason people go into cardiac arrest is that their heart goes into an abnormal rhythm called ventricular fibrillation. So is the screen any clearer now? Did the screen clear up at all? No?
A little better, but still bad.
No,
it's still unstable.
Okay. Hold on
How
one second.
about you send it to us on email? We look at it on another screen.
I'd have to have done that in advance. It'll take too long. Let me just see one thing. Let me just see if anybody else in my house is on the internet, and maybe that's what's hogging up some bandwidth. Just give me 1 second.
Meanwhile, guys, just a reminder, also signing off the link for skills intake with slide groups, 6 to 8 and 8 to 10, 15 people per group. Just a reminder.
Okay, is it any better now? I kicked some people off the internet. No better?
No, it's still off. It's still blurry.
Okay. Okay, I don't know then what we're gonna do. Is this picture blurry?
Yeah. Picture's blurry. The wording, you can't even read it. It's all
Mm-hmm.
really blurry.
Okay. Let me try one other thing. Okay. Just give me 1 second. Okay. Is that a little clearer? Can you see the picture of the heart now?
No,
No. You can't see the picture of the heart, or it's not clearer?
it's not clear.
It's not clear. It's a bit better, but still not as good.
Okay. I have no idea why it's not working. because it's crystal clear on my end. It's got to be something about the internet. Okay, we'll have to figure out what we're going to do then. So
I
basically,
think
go
I
ahead.
think you should share the link from everything in the chat box here on Zoom, so we can open it up.
Now it's much
So-
better. You just changed something. It's much better now.
Okay.
Yeah, it's actually flaring up a bit.
Okay. Yeah, I think it's just the speed of the internet. So what I'm going to do from now on is I will send out the PowerPoint lectures, you know, ahead of time, so that you could have them open on your computer and refer to them. Okay, so I'll make sure to get that done. Okay, I'm just going to mute everybody again because it's getting noisy. Okay, so basically this is a heart that's opened up, right? It's a cross section of the heart that's opened up. Just because I want to show you the concept of what the heart basically does. So it's one pump in the center of your chest, but this pump is divided into 4 sections, okay? And the upper chambers are called atriums and the lower chambers are called ventricles. And again, don't worry about the terminology too much tonight, because the more we do it, the more it will make sense to you. But before we talked about the concept of that, when somebody goes into cardiac arrest, the most common reason is an abnormal rhythm called ventricular. So these are the ventricles, fibrillation. So what the heart is supposed to do is it's supposed to contract, okay, like a muscle, right, and squeeze blood. When it goes into ventricular fibrillation, instead of 60 times a minute squeezing and pumping blood, it sits in the center of your chest, and instead of squeezing, it shakes. It almost looks like jello. It's just quivering, it's shaking. And when that happens, no blood is pumped out, okay? Now, when a muscle goes out of control and is shaking, the only way to stop it from doing that is to reset it. And the only way to reset it is to put electricity through the muscle and cause it to stop, in the hopes of that when it starts up again, it starts up in a normal rhythm. Okay, so now you've all heard that your body has a pacemaker, right? You've heard people go to the hospital and have an artificial pacemaker put into them because their pacemaker doesn't work. So we have a pacemaker built into our body that tells our heart to beat a certain time a minute, right? And the better shape you are, the slower your heart beats, because it doesn't have to beat and work as hard because you're in good shape. And the worse shape you're in, the faster your heart rate. So you can get a good idea of cardiovascularly what kind of shape you're in by looking at your resting heart rate. If your resting heart rate is 50, 60, you're in very good shape, okay? If it's 70, 80, you're in okay shape. If when you're resting, your heart rate is 90, 100 constantly, you're not in good shape. And the quickest way to remedy that is to, especially for those of you who have jobs where you're sitting at a desk all day long, is to get up and move around and walk, okay? Even if you, when you go home from work, you walk with your wife for, you know, an hour, and you should walk briskly enough that talking between the two of you becomes difficult. In other words, that you just want to walk and you don't want to converse. If you're walking slow enough where you can carry on a full conversation, you're not exercising your heart. But anyway, so we said that, you know, why do we have to do CPR? So we have to do CPR when people's hearts are no longer pumping effectively. And again, the vast majority of times when somebody goes into what we call cardiac arrest, when their heart is not beating effectively, it's because the heart goes out of a normal rhythm and goes into this rhythm called ventricular fibrillation. Now, we said the ventricles are the lower chambers of the heart. So the way the basic heart works is that, or at least this picture works, is that the blue blood vessels are called veins and the red blood vessels are called arteries. Okay, so you have 3 types of blood vessels. You have veins, which are what we call low pressure, right? So the blood in the veins are not a lot of pressure because veins are bringing blood back to the heart that's traveled all through your body and has given up the oxygen and given up the sugar and done its job, bringing it back to the heart to get fresh oxygen and sugar. So you see here, you have 2 veins and they're coming into the right upper chamber of the heart, the right atrium, okay? And all this atrium is kind of like a holding chamber. It doesn't do anything in here, but it goes through a valve, okay, once it fills up, into the right ventricle, okay? And then when the right ventricle contracts or squeezes, it pumps blood up into what's called the pulmonary artery. And obviously we said before that pulmonary means lungs. So the pulmonary artery, okay, brings blood to the lungs, okay? And why is it bringing it to the lungs? Because we just said that this blood was used up already. So it's bringing it to the lungs to get fresh oxygen. And after it goes to the lungs, it gets fresh oxygen, it comes back into the left side of the heart, and it's kind of hidden here, but into the left atrium, right? You had a right atrium on this side, you have a left atrium on this side. It comes into the left atrium, again, just a storage vessel until there's enough blood in it. And then it goes down into the left ventricle. Now, if you're looking at it very carefully, look at the thickness of the wall on the left side of the heart versus the thickness of the wall on the right side of the heart. or look at the thickness of how the atriums are compared to the ventricles. So the atriums, since they only have to pump an inch, are very thin. The right atrium, okay, is thicker than an atrium. I'm sorry, the right ventricle is thicker than the atrium is because the right side has to pump to the lungs, so it has to pump a little further. But look how thick the muscle is on the left side, and that's because the left side of your body the left side of your heart has to pump to your entire body. So when the left side pumps, it pumps up into this large artery, the largest artery of your body, called the aorta. And again, don't worry about the terminology. You're going to get it down at some point. Okay, pumps to the aorta, and the aorta then brings that blood to your entire body. So this is your first large artery off your heart, and it goes to your entire body. So the reason I'm doing this is that to understand that when somebody goes into cardiac arrest, this whole pumping action that I just described to you is not working right. And the term ventricular, meaning the lower part of the heart, fibrillation, is the most common cause of cardiac arrest. When this happens, the person goes into ventricular fibrillation. The only way we can save them, so we're going to talk about CPR tonight, but CPR is not going to bring somebody out of ventricular fibrillation. All CPR is going to do is pump blood and try to keep their organs perfused until, okay, we can stop that heart from shaking. And the only way we could stop the heart from shaking is to put electricity through it. So who knows how we put electricity through the heart? Okay, who took CPR or who has been reading their book and stuff like that? Who knows how do we put electricity through the heart? What do? We use something called the automatic external defibrillator, or AED, right? And the AED sends electricity through the heart to actually stop it. Like prior, maybe tonight, some of you said, oh, I thought the AED jump starts the heart like a car, right? But the AED actually stops the heart, and it stops the heart to give your natural pacemaker time to take over and beat normally. Okay, now, the likelihood of that happening depends on how quickly we defibrillate somebody. And that's why states allow even non-medically trained people to use AEDs. So you've seen AEDs in the bank, in the supermarket, you know, and houses of worship, in the gym, and everything like that. So New York State is one of, you know, most of the states in the United States that have laws called public access defibrillation, which means that a layperson can use an AED to help someone with no medical training. And the reason why is that AEDs are, I don't want to use the term idiot proof, but they're pretty idiot proof, which means that if you could figure out where the on button is, it will talk you through every step of the way, and it will actually analyze the rhythm for you, and it will only shock if the patient needs to be shocked, if they're in a rhythm that requires defibrillation. And there's only 2 rhythms that require ventricular fibrillation, and you're not going to need to know if they're even in it or not, okay, because all you have to do is assess the patient and find that they're without a pulse. And if they're without a pulse, you're going to put the AD on them. The AD is going to analyze the rhythm and decide whether it's what we call a shockable rhythm or a non-shockable rhythm. If it's in a shockable rhythm, it will say stand clear, charging, and press the button to shock, and it'll shock the patient. And the speed at which you do that depends on whether or not the patient lives or dies. So in other words, if somebody were to go into VFib in front of you, okay, and you defibrillate that person, there's a good chance they may actually, if they've only been down, you know, a minute or so, there's a good chance they may wake up and say, who are you? What happened? You know, why am I here? Why am I laying on the ground? Why is my shirt open? Why are these pads on my chest? They, you know, they may not even know that they actually, well, they wouldn't know that they actually went into cardiac arrest. Now, if you came 10 minutes into it, 15 minutes into it, the likelihood of them surviving that cardiac arrest is not going to be great because their heart has been deprived of oxygen and sugar, their brain has been deprived of oxygen and sugar for a longer period of time. So that's where speed, you know, most of the times in EMS, speed doesn't matter, okay? But this is one situation where speed matters, right? So if somebody's bleeding to death, speed matters. If somebody's in cardiac arrest, speed matters, right? A lot of times the nonsense stuff that you're going to think that people are only going to call you to help them in true emergencies. You'll rapidly find out that 90% of what we do is nonsense, okay? And people call you to remove ticks. People call you because there's a little cut. People call you, actually in the Jewish world, people call you because they don't want to go to the hospital. And their first question to you is, you know, I don't have to go to the hospital, right? And you say, well, you just called the ambulance. You know, well, yeah, I called the ambulance because I don't want to go to the hospital. You know, in the non-Jewish world, people would be scratching their head. But in the Jewish world, you know, when I first came to Rockland County in 1988, that's all, I didn't have paramedics. So we used to go on every call, you know, and it was a eye-opening experience for me when you walk in the house and they say, you're not taking me to hospital, are you? And you'd say, well, you called the ambulance. That's what we do. No, 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 that's not what the Jewish ambulance does. You know, we call you because we don't want to go to the hospital, and you have to make us better in the house because we can't go. We don't want to go to the hospital. So you'll see that it's, especially if you're going to, you know, strictly be operating with a Jewish clientele, that it'll be a little different. Okay, so going back to this concept of why do we do CPR? So we do CPR to try to keep the organs of the body perfused. Now, if you hear a story where somebody says to you, they did four compressions. They compressed 4 times on a person's chest. The person woke up and they saved them. That patient was never in cardiac arrest. Okay, that patient fainted, right? They just, like if you fainted, if you were dehydrated or, you know, whatever, and you fainted, you were asleep for a second because your brain wasn't getting enough blood. And why did they wake up? Why did they, quote, save that person? Because the pain of you compressing on their chest woke them up. So you feel good, you think you saved the patient, right? But really that patient was never in cardiac arrest. If somebody's in cardiac arrest, they're not going to come back to life with CPR. But that's not to say that CPR is not important, because CPR is what people do to keep the other person's organs alive until more advanced care can come. So you are now going to be the person, you know, rendering that advanced care. I remember, you know, we were doing an EMT class in KJ, and while we were doing EMT class, there was a cardiac arrest in a shul of a young person, 20-something-year-old person, who, you know, in the middle of davening, just collapsed to the ground. And at first, everybody just thought, you know, first, is he faking? You know, did he just faint? You know, what the deal was. But fortunately, there were 2 guys from Hatzola. They had their AED. They put it on. It said shock indicated. So he can't be faking, right? If the AED says he's in a rhythm that needs to be shocked, the AED doesn't make mistakes. So they shocked him, and he survived. And if they were not in that shul, okay, with that AED, the likelihood of him having such an amazing, you know, outcome, and really, you know, having no deficit, no long-term problem, would not be, you know, would probably not be as likely. Okay, so the speed of defibrillation is very, very important. Okay, so does everybody get the kind of, again, I know we're just briefly touching it, the concept of that your heart is a pump, right? And it's pumping blood. The reason blood is important is because it contains what we call the nutrients, the things that the body needs to stay alive. So for you to stay alive on a very basic level, you need a functioning pump, which is a functioning heart. You need blood vessels that are working, okay? And you need the blood to contain the important things that it has, the sugar and the oxygen. And you need that to go nonstop, okay? While you're sleeping, you know, while you're awake, nonstop, for your whole life, obviously. So today we're talking about, you know, what happens if somebody's heart is not doing that. And as a short-term treatment, CPR is what we're learning, okay? So let me bring up something else, and we'll talk about the actual CPR. Let's see. Okay. Now, I emailed this out today, right? So everybody can see. Let me get to the front page. Can everybody see this thing that says Village and New Square Ambulance Service? Yes? Yes, yes?
Yes.
Okay.
Yes.
Okay, so this was actually, I think, one of our first EMT classes we did in New Square, and somebody was nice enough to take notes, and then I kind of fixed them up and stuff like that. So let's go through, you know, some of the things we talked about that night. So unconscious means obviously a patient's not awake. So we have an unconscious patient with a pulse and breathing. So they're not awake, but they have a pulse and breathing. So they're not in cardiac arrest. They just fainted. And the term in medicine of fainting that you're going to use from now on is syncope. When they say somebody fainted, they say syncopize. Okay, so they don't really, when you go to the hospital, in other words, you're going to go into the hospital and you're going to have to learn to speak the language they speak. Okay, and the reason why is it builds more credibility. You know, like, you know, everybody has a business, everybody has something to do. When you're talking to people in your business, you're using the terms of your business. If somebody all of a sudden starts talking to you, trying to pretend they know your business and they don't know the terms, you right away know that they're not, you know, they don't really know your business. The same thing in medicine. So we want to be respected by the people in the hospital, the doctors and nurses and people that we interface with at the hospital, and we have to start learning their lingo, their terminology. Okay, now, but I'll say one thing. If you have no idea how to say, okay, the term, then just describe it in basic English, right? It's better to describe it in basic English than to say the wrong term, and then they're looking at you saying, like, you know, what the hell are you talking about? That couldn't be, you know, with that patient. So, but you'll start to learn these terms. So syncope Fainting, the same thing. So it's the way they in medicine, they talk about, somebody fainting. Now, all fainting means is that the patient is alive, but they're not awake. And again, as we go on in class, you're going to find out there's a million different ways why people could still be alive but not be awake, right? So their sugar could be low, their oxygen could be low, they could have had a seizure, they could maybe be taking a drug that affects them. So there's a lot of different reasons. So if you come on a call and that patient's not responsive, you're going to be nervous, right? They're not awake. The first thing you have to do is take a deep breath and see, do they have a pulse? Now, we'll talk about how to check a pulse and where to check a pulse, and they'll show you, where to check a pulse when we do CPR. So I guess I should say, what is a pulse? A pulse is what you feel when you press on an artery, when the heart is pushing blood through. So you're feeling the pulsation or the pushing of the blood through the blood vessel, okay, every time the heart contracts. So if you feel a pulse in a blood vessel, the patient's heart has to be pumping, okay? So now we're saying that you have a patient that's not awake, but they're alive. They have a pulse and they're breathing. What do we need to do for them? So what we want to do with them is we want to put them on their side. It does not matter what side. Years ago, we used to be very strict that it had to be on the left side, but there's no medical reason why it has to be on the left side or right side, to be honest with you. Okay, everything pretty much in your body is kind of in the middle of your body, so it doesn't really matter left side or right side. But most people do put them on the left side, and depending on the type of ambulance you're in, if it's one of the smaller, narrower ambulances, you'll see that if you put them on their right side, so it would be the opposite of this picture, they would be facing the wall and you wouldn't be able to see them because there's only room on one side in the narrower ambulances. In the bigger box ambulances, there's room on both sides, so it doesn't really matter. Okay. Most of the times we put them on their left side unless there's an injury on their left side, and then we'd have to put them on the right side. And we put them into a position called the recovery position. Okay. So what all it means is that because they're unconscious, there's a chance that if they were to vomit, okay, they could actually choke on their vomitus. And that's the term for that is called aspiration. It's going to be a term you hear all the time. So again, this patient's conscious, they have a pulse, they're breathing, you're taking them to the hospital. Obviously, as we go on in class, we're going to talk about things you could do to examine them and try to see if there's something you could do to help them to wake up, okay? But right now, we'll just worry about that we're transporting them, okay? So again, we're going to put them on their side. And unfortunately, in medicine, there's a term for being on their side. So on their side is called laterally. So you'll see when we do anatomy, we'll talk about lateral means going out to the side. Recumbent, okay, those of you that bike, like a recumbent bike means you're kind of like laying down when you're on it. So laterally recumbent, okay, so that's all it means. And if you had to really document it well, if you had them on their left side, you would say they're left laterally recumbent. If they're on their right side, they'd be right laterally recumbent. And that brings up a good point. When we talk about left and right, when we're referring to a patient, it's the patient's left and right. It's not our left and right. So when we're looking at this guy, this arm is actually his right arm. Even though when we're looking at it, it's kind of more towards the left side, it's actually his right arm. So whenever we're referring to something from an anatomy standpoint on a patient, it's always their right or their left. And again, this is to prevent them that if they were to vomit from choking on their vomitus. Okay, so now let's go the other way. They have no pulse and they're not breathing. So they're in cardiac arrest. Okay, now in cardiac arrest, we said we have to start CPR. We divide CPR basically on the age of the patient, okay? So years ago, they went by strict ages. They used to say over 8 years old was an adult, 1 to 8 was a child, under 1 year of age is an infant. This has kind of got modified a little bit where they use a term called puberty. Puberty is the medical term when somebody changes their body, changes from being a child's body to an adult body, which typically, happens somewhere around, say, bar mitzvah time, right, or bas mitzvah time, okay? So when children start looking more like adult dimensions, so in men, let's say their voice gets deeper, in boys, their voice starts to get deeper, not that you'd be looking, but they would get pubic hair, hair in their personal spots, girls would get breast development. That's when they're starting to change from a child's body to an adult's body. So here they're saying around 8 years of age. Nowadays, they kind of say you look for signs of puberty, that they look like they're becoming an adult. So here's what we have as far as numbers go. So when CPR is very fixated around numbers, okay? So one person CPR, you're by yourself, that means. You would do 30 compressions to 2 ventilations. So that means you compress 30 times on their chest, then you would give 2 breaths. You go back and do 30 compressions and 2 breaths. And CPR is built around 2-minute cycles. So in about 2 minutes, you would get 5 cycles of 30 compressions and 2 ventilations, and if you're in good shape. Okay, so we'll go over these numbers a lot. Okay, and then obviously on Sunday you'll go over them a lot. Okay, and nicely the AED actually talks to you and kind of keeps you on track with your CPR. It actually gives you a little metronome, a little tone on when you should compress and ventilate. Okay, so you'll see that on Sunday. So all adult CPR is 30 to 2. Okay, so it doesn't matter if you're doing 1 person or 2 person CPR. Now, look at the difference between child and infant. 1 person CPR on a child is 30 to 2, but 2 person CPR is 15 to 2, and the same thing on the infant. So the numbers change because they found by studies, you'll hear a lot in medicine studies, where they examine different ways of doing things and trying to find out the best way to do it. So they found by study that when you had 2 trained people doing CPR on a child and infant, they actually circulated more blood when they did 15 compressions and 2 breaths than 30 compressions and 2 breaths. And the reason why is they got more sets of compressions in that 2 minutes. Okay, why it doesn't pertain to adults, I don't know, but that's what they picked. Okay. So again, we'll come back on this, but this is the numbers that you're going to remember when you're doing CPR. Okay, you're going to have to remember that the person who's compressing compresses 30 times, the person who's ventilating gives 2 breaths, then the person goes back and compresses. It may seem crazy now, trust me, you know, by the end of Sunday, it'll make sense. And, you know, halfway through the class, you'll be doing it without even, without even thinking it. Okay. Now, we had 2 things so far. We had the patient who had a pulse and was breathing but was not awake, and we called that syncope or fainting. And we said, really, for right now in CPR, we're just going to put them on their side. Okay. Later, we'll talk about checking their sugar levels and their oxygen levels and deciding if we need to give them some sugar or give them some oxygen. But for right now, we're just going to put them on their side to prevent them from choking on their vomitus. And we use that term, choking on their vomitus, something called aspiration. Okay. Then we talked about a patient who had no pulse and not breathing, and they were in cardiac arrest. There we had to do CPR. Okay, and CPR is a combination of pushing on their chest and breathing for them. So we do both things. The last thing we're going to talk about is the patient has a pulse, so their heart is actually working, but they're not breathing. Okay, so now the problem is that if we don't breathe for them, what's going to happen to their heart? It's going to be deprived of the oxygen it needs, and it's going to stop beating. So here we have a situation where we don't need to do chest compressions because their heart is beating on its own. We need to breathe for them. Okay, so instead of calling it cardiac arrest, we call it respiratory arrest. And here we do something called artificial respirations, or we ventilate the patient. We breathe for the patient. Now, you may have heard, mouth to mouth, where you put your mouth on a patient. Nobody on an ambulance puts their mouth on a patient. Okay, you're going to have equipment, and that's what you're going to use. The only time you're going to put your mouth on a patient is if somebody in your own household who you love and you don't have equipment. Other than that, there's no such thing as putting your mouth on a person that you do not know, especially in this time of COVID now. But even before, I mean, you could talk to anybody who's been in EMS for long enough, and nobody's ever put their mouth on a patient. Okay, so that's just something, I don't know, that I guess maybe lay people do that have no training or something like that. So now we need to breathe for the patient. Okay. So somehow or another, some of the numbers disappeared on here, but I'll fix it up when I send it out to you again. But we're going to give, for an adult patient, we're going to give 1 breath every 5 to 6 seconds. Okay. And for a pediatric patient, 1 breath every 3 to 5 seconds. And for an infant patient, 1 breath every 3 to 5 seconds. And I'll fix it up before I send it out. I don't know why it disappeared on the page. Okay. So all we're basically doing is we don't need to compress on the chest. We're going to use a device called a bag valve mask, something that we put a mask over a patient's face and we squeeze this bag and force air into them. Okay, and again, these are numbers that you will kind of commit to memory, okay, throughout the class. Okay, so now let's talk about some other things. CPR. So now you're there, you're the basic life support ambulance, the EMTs. You started doing CPR on a patient and the paramedics come, okay? So CPR changes slightly in that case because once the patient has a breathing tube inserted into the lungs, which only paramedics in the field can do, and obviously in the hospital, doctors and anesthesiologists and stuff like that, it changes from having to do a certain amount of compressions and a certain amount of breaths like we had up here to basically the person who's doing CPR compresses continuously. And the rate of CPR is 100 to 120 compressions per minute. So what's really going to happen is that the person is going to compress and just go count to themselves and go 1 and 2 and 3 and 4 and 5 and 6. And they're not going to have to stop at 30 or 15 like we set up here. And the reason why is that this tube is directly into the patient's lungs. So when who's ever ventilating a patient and squeezing the bag valve mask, they are guaranteed that every ounce of air is going out in the patient's lungs. When we were up here, we just have a mask strapped over the patient's face. And if you were trying to squeeze air in at the same time that somebody was compressing on their chest, you're actually just blowing the air out. So that's why here we actually have to stop the compressions and give the 2 breaths. Where here, we don't have to coordinate. So the person who's compressing just counts themselves 1 and 2 and 3 and 4 and 5 and compresses until they're tired, or 2 minutes goes by, because typically we don't have people do CPR for more than 2 minutes because they get tired. And the person who's ventilating counts themselves and gives 1 breath every roughly 6 seconds, like we set up here. Okay. Now, CPR, I said, is delivered in kind of a 5 compression, 2 ventilation, unless the patient has that advanced airway in. And you're either going to use 30 to 2 or 15 to 2, depending on the age, right? We said all adult patients get 30 to 2, and how many people are doing CPR. So that's what we're talking about up here, right? So on this side, all the adult is always getting 30 to 2. Child and infant, it differs between if you're doing 1 person or 2 person. If it's 1 person, it's always going to be 30 to 2. And if you're doing 2 person, it's going to be 15 to 2, but only on the child and infant, not on the adult. So obviously you can see these numbers are a little confusing. So you know that the state loves to ask these types of questions on the exam because it's quick, easy questions to make. You know, how much CPR do you do on an infant? How much CPR do you do on an adult? What if you have 1 person? What if you have 2 people? So these are numbers that right now you might say, oh my God, you know, I'll never remember it. But again, trust me, I've been doing this for a while. You will absolutely remember all this stuff by a month from now. It'll be you won't even think a second of it. Okay, so we said it's 5 compressions to ventilations. Okay, and after 5 sets, you're going to reassess the patient. Now, if you don't have an AED, that means you're going to have to check for a pulse. Okay, and typically we check for what's called the carotid pulse in the neck. But if you have an AED, the AED is going to tell you to stop CPR, and it's going to reanalyze the patient's rhythm to see if it needs to be shocked. Okay, so I wrote over here 32, 32, 32, 32, and then reassess. Or if you're doing 15 to 2, that's what you would do and reassess. Okay, doesn't matter which type of CPR you're doing, adult, infant, or child, you're delivering it at a rate of 100 to 120 compressions per minute. But obviously, you know, if you were doing this type of CPR, you don't actually get those compressions in because you have to stop to ventilate. Okay, but if you were doing this CPR where the advanced airway is inserted and the person was doing CPR correctly, you may get 100 to 120 compressions in. Okay, now, so again, test questions. Maximum recommended time that someone should perform CPR. Okay, so really they don't want anybody doing compressions for more than 2 minutes because they get tired and they don't compress adequately. Okay, so that's, you know, now, some of you, saw the ambulance or been on the ambulance. You see now that most ambulances have machines to do CPR. Now, obviously, if you're responding from your house to someone's home and you're there first, you're not going to have that machine because it's $25,000 in your car. Okay, you have to wait for the ambulance to come. So you still have to know how to do manual hands-on CPR. But once the ambulance arrives, typically we strap a machine, and we'll show you that on Sunday in class. There's a machine that does CPR. So, and the machine, is not a human. It doesn't make mistakes. It's battery operated. And as long as you put it in the right place on their chest, it's going to compress until the battery goes dead. And with our short transport times to the hospital, you don't have to worry about the battery going dead. So you'll have a machine doing CPR the whole time. Now, again, if you're doing hands-on CPR, we know that we have to compress deep enough, right? If we don't compress the sternum, the breastbone, the chest bone down onto the heart, it's not going to be compressed between the heart and the backbone, and it's not going to therefore pump out blood. Okay, so now we have to look at the terminology. So it says for adult at least 2 inches. So at least 2 inches means what? That it's actually greater than 2 inches, right? At least means you're getting at least to 2 inches. So it's probably a little more than 2 inches. Where a child, it says about 2 inches or around 2 inches. So that's right around that number. So adult is a little more than 2, child is at 2, and an infant is at 1.5 inches. To make it, now, I know everybody's saying, how the hell do I know how deep I'm compressing? And I have to tell you, this is something that, people wrote in a textbook, and we have no way of knowing, right? We have no way of knowing whether we're compressing half inch, inch, 2 inches. But I will tell you that people, once you start doing CPR on people, you kind of develop a routine and you get, you get good at it. You get an adequate idea of how deep you're compressing. Just again, as a test question, the other way they ask it is 1/3 the distance from the top of your chest to your back. Okay, so again, we can't measure it. We don't have a way of measuring it, but roughly 1/3 the diameter of the chest that you want to compress. Okay. The other thing they're going to stress is that compressing down pushes the blood out, but it's also important that you let the breastbone, the sternum, come all the way back up. And that's because when the breastbone, when the sternum comes all the way back up, you're creating what's called negative pressure in the chest. Okay. So you're like, when you're downstroking, you're putting pressure. When you're coming up and letting the chest relax, that pressure goes away. And what the heart actually does is suck blood into it. So if there's ever a test question that says, when does the heart refill with blood? It's in the relaxation or upstroke phase. In the downstroke phase, that's when we're pushing blood out. Okay. Okay. Let's finish this page and then we'll take a couple minute break. So the other thing we need to talk about is somebody who's not in cardiac arrest but is choking, has what they call an airway obstruction. Okay, so obstructed airway or airway obstruction. So obstruction means that it's blocked somehow. This is actually, you know yourself, much more common than somebody going into cardiac arrest. I mean, everybody's seen somebody who's choked or almost choked on a piece of food or a toy or, candy or something like that. So this is something, that you probably come upon more often than someone in cardiac arrest. I have to tell you, in EMS, we don't a lot of times go on choking. I shouldn't say we don't go on choking calls, but we don't get there when the patient's still choking because people, bystanders, family members, usually will not stand by and do nothing, and they will try to help the patient. And it's, for the most part, people usually can clear an airway before we get there. Once in a while, no. Okay, but for the most part, they can usually clear an airway. So when you get there, the airway's already been cleared. The patient is, trying to breathe. They're awake. They're coughing, and you're just there kind of to offer moral support and transport, them to the hospital. Again, maybe not in the Jewish world. Maybe they say, okay, they got it out and I don't need to go to the hospital. But, in the non-Jewish world, most people who choked on a piece of food usually go to the hospital and get checked out. So the term here is a conscious adult and children, okay? So a child, again, we said is roughly somebody that's past puberty or at least 8 years of age, right? So they're awake, they're choking. How do we know they're choking? We ask them if they could speak. So if they can talk to us, they're not choking. They may be coughing, they may feel like they have something in their throat, but if they could speak to us, they have an airway. Air is getting into their lungs because to be able to make sound, air has to go down past a structure in your throat called your vocal cords. And if it goes past your vocal cords, it's getting into your lungs. So we've all eaten something too big or scratched the back of our throat with something and we felt very uncomfortable. We may have been coughing, we may have been gagging, but if we're talking, we are not choking. So if they're talking to you, you just encourage them to cough, okay? And there's nothing else to do, okay? If they stop talking or stop coughing, then they may have developed a complete airway obstruction and we may need to intervene. So the procedure that we do when a patient's conscious is called the Heimlich Maneuver, which again, you're going to learn in class on Sunday, but basically we're going behind the patient and kind of pulling up underneath their diaphragm, their muscle that separates their chest from their abdomen. And the reason we're doing that is we're trying to push up onto the lungs and take that residual air that's stuck in their lungs and blow it out against the obstruction, okay? So that's what we do for a conscious adult or conscious child. If while we were doing that, we were not successful and their oxygen level starts to fall and they become unconscious, we lay them down on the ground and we start CPR on them, okay? And again, this will make more sense on Sunday when we practice it in class. Now, an infant is completely different. So an infant, the problem is that you don't want to take your big, strong hands and be pulling on their belly because you can cause abdominal injuries. So an infant, if they're not crying, again, they can't talk to you because they're an infant, but they're not crying, okay, and doesn't look like they're breathing, we do a combination of back blows where we strike them with the heel of our hand between their shoulder blades and chest thrusts where we push down almost like we're doing CPR and we try to relieve the airway that way. And again, they'll show you how to do that when we do it. Okay, so why don't you guys take, what time is it now? It is 8:54. Come back at 9 o'clock, okay, and we will we'll pick up, so use the bathroom, get a drink, stretch your legs, get some blood flowing, and we'll come back at around 9 o'clock, okay? So go take a break. Okay. I should have remembered to pause the video, but okay. Does anybody have any questions before we go on anything we went over? Okay. Okay, so let's talk about some vocabulary and some terms pertaining to the heart, and we'll go back. So when we're looking at medical words, there's what they call a prefix, and there's what they call a suffix, okay? So myo, just again, to start to introduce it, so you see the arrow goes down to muscle. So myocardium is the term for heart muscle. And you're going to hear when we get into the cardiac section, a myocardial infarction, which is a term for a heart attack, okay? So myo meaning muscle, cardium, the cardiac heart, okay? The other thing you're going to hear a lot of is the term tachy or brady. So tachy means fast. Cardia, again, you know already is heart, okay? So tachycardia means a fast heart rate, and they define that as a rate over 100. And bradycardia is a slow heart rate, okay? So trust me, I know a lot of you are saying like, I'll never get these words down, but you will, okay? For most of the students, I hear that using their wives to help with a lot of this stuff, or at least repeating it back to you or helping you to pronounce it is a good way of doing it also. Okay, so we talked about that the heart is a pump in the middle of the chest, and it has 4 chambers, right? And we said the upper chambers were called atriums, and they're divided between right and left. Again, patient's right and patient's left. So when we're looking at this, over here, right, even though it's on our left side, it's the patient's heart. So it's the right atrium, right ventricle, left ventricle. The way the heart works is that both atriums contract and push blood down to both ventricles, and then both ventricles pump into their arteries, right? So the right side, we said, pumps to the lungs through the pulmonary artery. The left side pumps to the whole body through the aorta. And that the atriums are very thin-walled vessels because they don't have to pump very far. They only go down to the ventricles. And that the right ventricle is a little thicker than the atriums because it has to pump to the lungs, which is not very far away. Remember, it's all in the center of your chest. Where the left ventricle is a very thick part of the heart, right? The muscle is very strong because it has to pump to the entire body. Okay? Now, one of the things we didn't talk about is the concept of, we said cardiac arrest, but you all heard the term a heart attack, right? And a lot of people think a heart attack means a patient is dead. Now, if you go back 20 years ago, people who had heart attacks a lot of times did die. But nowadays, we have a lot to do for patients that have heart attacks to prevent them from dying. And it really starts with either them or us being EMS, because a patient having a heart attack, one of the most important things for them to do is to chew aspirin, okay? And aspirin has the ability to stop clots from developing in the body. And when somebody has a heart attack, it's because a clot has developed in the arteries that give the heart the blood it needs itself. Because remember, the heart is a pump, it's a muscle, so it also needs oxygen and sugar. So it has its own network of blood vessels to give it that. And when somebody has a heart attack, one of those blood vessels or more than one of those blood vessels is blocked. And that causes somebody to develop pain in their chest because there's not enough oxygen getting to the heart muscle, okay? And like I said, if they take aspirin, okay, it's not going to prevent them from having a heart attack, but it's going to give them more time to get to the hospital to do a procedure called angioplasty, where they actually go into the artery and balloon it open, or kind of force open the artery that got clogged to reestablish blood flow, okay? So just talking about it, you know, we have this network of blood vessels, okay, that go across the outside of this heart. If you ever heard bypass surgery, that's the blood vessels that they're trying to bypass or fix because they're clogged, okay? So if you know what you know about the heart right now, if I just asked you a quick test question, and I said to you, which chamber of the heart do you think is the most important? Okay, the one you'd least likely to have a heart attack involving, what would you answer? Would you answer in atriums or ventricles? So we know probably that ventricles are more important than atriums, right? Because atriums only have to pump down to ventricles. And then if I said to you to decide between, is the right ventricle more important or the left ventricle? Now, I'm not saying that any part of the heart is not important, right? I'm just saying, like, theoretically, which is the most important part of the heart and the one you'd least like to damage, that would be the left ventricle, because the left ventricle pumps to the entire body. So if the left ventricle is damaged, the chances of somebody having a normal life and functioning fully is very, very slim, okay? So when somebody has, we'll learn later, the degrees of heart attacks or the types of heart attacks or, you know, the outcomes of heart attacks. And the left descending coronary artery, okay, the one that comes down and services, I don't know where the mouse is, let's see, services this part of the heart, it has a nickname called the widowmaker. So a widow is a woman who's lost her husband, right? So the reason it's called a widowmaker is that men have heart attacks more likely than women, okay? And when the left descending coronary artery is blocked, it services the left bottom of the heart. So it services, it gives blood to the left ventricle. So that means that somebody's having a heart attack involving their left ventricle, so their outcome is not great, okay? Remember, if you have questions, just unmute yourself. Okay, so let's kind of start wrapping up and we'll talk about the types of cardiac arrests and what we could do for them. So this patient has no pulse. They're going to be in one of these three rhythms. So the three rhythms are called asystole, ventricular fibrillation, okay, or pulseless electrical activity. Asystole means the heart has completely stopped. So when you look at an EKG and you see all the bumps and stuff like that, that's telling you the heart is trying to do something, right? It's trying to contract and push blood. Now, I'm not expecting to learn EKGs and stuff like that, but there's normal EKGs, there's abnormal EKGs. But when you see an EKG where it's just a line going across the screen with no activity on it, that means the heart is completely stopped. So if the heart is completely stopped, that means there's no blood flow. If there's no blood flow, the patient is dead, okay? The AD has no role here because the AD stops the heart in the hopes that it'll start up in a normal rhythm. Here, the heart is already stopped. So the only thing we could do on a BLS level is good CPR and either have the paramedics respond to administer medications to that patient to try to get their heart beating again, or if there are no paramedics, let's say you're up in the mountains and, you know, whatever, it's a work day and the paramedics are in Brooklyn, you know, you would transport that patient to the closest emergency room to have the same thing done. Now, what's the survival rate of somebody in asystole, right? No cardiac output. It's called asystole. It's very poor, obviously. There's not really a high likelihood of survival in those patients. In fact, you know, here in Rockland, if we have what we call an asystolic, means an asystole cardiac arrest, and we don't get anything back within a couple of minutes, a lot of times we'll just pronounce the patient and leave them in the house. There's nothing really to do for them. The likelihood of them surviving are pretty poor. Again, in the Jewish world, you know, everything usually, most patients get transported because nobody wants to tell the family, you know, we're giving up on them, you know, there's nothing to do for them. So a lot of times they will transport an asystolic cardiac arrest. Again, the patient doesn't survive, they die at the hospital, or the family's told the patient's dead at the hospital versus being told the patient's dead in the house and having the patient, you know, in the house. So just a difference in culture. Okay, now, the other one I told you about is ventricular fibrillation, right? So look what happened in VFib down here. So instead of, now here's an, you know, this would be, believe it or not, a normal rhythm, but it just, I'll talk about why we have it under pulseless electrical activity, but this is what the rhythm most of us are in right now, okay? Sorry, I couldn't hear. And look at the difference over here. So here it's beating nice and regular, okay? Probably somewhere about 50 times a minute. Here it's just this chaotic up and down. So now the patient went into ventricular fibrillation. Okay, we'll leave out the pulseless ventricular tachycardia for a second here. But the patient went into this abnormal rhythm from ventricular fibrillation. Somebody's probably thinking or wants to ask, why does somebody go into asystole? Why does somebody go into ventricular fibrillation? Why does somebody go into PEA? So those are all good questions. I mean, people go into asystole because they've had a massive heart attack and they've damaged their heart beyond repair, okay? People can go into asystole because they suffocated, they couldn't breathe, and the heart was deprived of oxygen. So there's a lot of different reasons. Believe it or not, your heart's a muscle. The muscle could burst, right? And the patient blood just empties out of their heart. So there's a lot of different reasons why people's hearts can just stop. With ventricular fibrillation, a lot of times, believe it or not, it's just not somebody's lucky day, right? In other words, you have this pacemaker, like any type of piece of equipment, sometimes it malfunctions. So for most of us, our pacemaker, like I said, is going to beat 60 times a minute for the rest of our lives and have no issue whatsoever, okay? Sometimes that pacemaker, instead of sending out 60 beats per minute, sends out 6,000 beats per minute because it's malfunctioning. And the heart can't process all those commands. It can't beat 6,000 times a minute. So instead of contracting and squeezing blood like it's supposed to, it shakes because it can't handle all that information. and the patient immediately loses consciousness and dies. Now, if you find that and you don't have an AED, you're just you yourself by yourself, you would start CPR until the AED comes, okay? And you doing CPR is not going to get the patient out of VFib, but it's going to slow down the chances of that patient dying permanently because you're going to keep their organs somewhat perfused. Perfectly done CPR is only 25% as effective as a beating heart, but it's better than zero, right? So whatever you do is better than nothing for that patient. Now, just one thing I'll mention is that if you're totally by yourself, right, you have no equipment, I don't know, you're out with your family, you know, it's Halloween, you're out with your family, somebody collapses, you have no equipment, okay? You're willing to do chest compressions on that patient that's in cardiac arrest, but you're not going to put your mouth on that patient because you're concerned about diseases. Is that acceptable to do compression-only CPR? And the answer is yes. In EMS, we don't typically do that because we have equipment. We have bag valve masks. We have things that we could do to ventilate a patient and not put our mouth on them. But let's say you're totally by yourself and you're more than willing to be the good Samaritan and do CPR, but you're not putting your mouth on that patient. It's totally acceptable to do compression-only CPR. And you shouldn't feel guilty about it because when somebody goes into VFib, they have no idea they're going into VFib, right? There's no warning signs most of the times, okay? So before they actually die, their oxygen level in their body usually is totally normal. And that we always have more oxygen in the body than we need. So for that first couple of minutes they're in cardiac arrest, there's plenty of oxygen still in their bloodstream. The problem is that because the heart is not contracting and pumping, it's not circulating. So you coming over and just doing chest compressions on them, you're actually circulating that oxygenated blood. So in the short term, compression only CPR, just compressing, just pushing on the chest, is acceptable as real CPR, full CPR. You know, obviously it'd be better if you could ventilate them, but again, there's no expectation on anybody's part that you're going to put your mouth on someone, you know, because you're concerned of, you know, disease transmission. Remember, we'll always say, you know, whose safety comes first, and it's not the patient's safety. Our safety always comes first. The goal is that you go home at the end of the day, okay, and with the same amount of arms and legs and the same amount of diseases you had at the start of the day. You don't want to pick up anything new, okay, and stuff like that. I remember I taught an EMT class and I was trying to, you know, stress, we were in the midst of a very bad stomach virus season, and I was really trying to stress to the students, you know, the importance of gloves and washing their hands and stuff like that. And, you know, student didn't come to class one night, and the next morning I get a text from him and he says, I got it. And I said, well, what'd you get? And he goes, well, I got your lesson. And he goes, and I got that stomach virus. And he said, I won't be to class again tonight. So, you know, here he was, EMT student riding on the ambulance. And, you know, he didn't put his gloves on. He didn't wash his hands. And somehow from helping a patient who had the stomach virus, he contracted the same stomach virus. Okay, so when a patient's in VFib, we do have something that we could do. In asystole, again, on a BLS level, EMT level, it's CPR and transport, right? On a EMT level VFib, believe it or not, we could pretty much offer similar care as the paramedics do, okay, as they do in the hospital, at least for the first couple of minutes, because the most important thing for somebody who is in ventricular fibrillation is defibrillation, is to shock them, okay? And we have an automatic external defibrillator, right? So every ambulance has an automatic external defibrillator. They're not cheap, but I mean, you can get an AED for under $1,000. So some people who have money actually go and buy their own and stuff like that. So, you know, people do have AEDs. And like I said, most places have AEDs. You know, I mean, most schools have AEDs, most supermarkets, most banks, most gyms, you know, I mean, dentist's office have them, doctor's offices for some reason don't have to have them. They usually do, but they don't have to, but dentist's office have to. So there's plenty of AEDs out there. It's just a matter of knowing where they are and knowing how to use them. Now, again, knowing how to use them, you're going to know how to use them within 30 seconds of class next week, because all it does is, all you have to figure out is where the on button is, and it talks you through every step of the way, and you can't actually get ahead of it. In other words, you have to wait for it to talk to you and tell you what to do, because it's not designed for somebody with training. It's designed for a lay person, a non-medically trained person to pull off a wall. Okay, so an AED will analyze the rhythm for you. If it determines the patient's in VFib, or again, we'll talk a little more later about this pulseless VTAC, it will say stand clear, energizing, which means it's putting the power into the machine to shock the patient. And once there's enough power generated into the machine to shock the patient, it will say push the flashing button to shock the patient. Now, if you are the person who's operating the machine, the responsibility is on you that before you press that button to shock the patient, you make sure nobody's in contact with that patient. So everybody else who's helping, they cannot be touching that patient, because it is possible for the shock to leave the patient and enter into somebody else. Okay, not as likely nowadays as it was years ago, but it is likely. And the last thing you would want to do is, besides defibrillating the patient, is defibrillate your partner and, have to explain to him why he went flying, down onto the ground screaming in pain. And there's obviously, if defibrillation is designed to stop the heart, right, in the person who's in VFib to let it reset, there is a theoretical concern that if somebody else accidentally gets shocked, that you could take somebody who's alive and was helping on that call and stop their heart, okay? And, then obviously you would have a lot of explaining to do. Nobody would want to be having you on their team anymore, because you'd be, known as the killer. Now, the last rhythm, and we're not going to really know, on an EMT level, is something called pulseless. Means, again, there's no pulse, electrical activity, or they abbreviated PEA. What it means is that if you actually had the ability to look at an EKG, they may be in a totally normal rhythm. Like I said, this is a normal rhythm that we're all in right now. They may be in a totally normal rhythm that should be generating a pulse, and they should be alive and talking to you, but for some reason they're not. Okay, and there's a lot of different reasons why this could happen. Okay, we're not going to get into all of it tonight. Okay, but basically what's happening is that the electrical part of the heart, the pacemaker, is sending out a totally normal signal that should make the heart do what it needs to do. Okay, but the mechanical part, the squeezing part of the heart, is not working. So remember, there's two parts to the heart. There's the brain to the heart, the pacemaker that tells the heart how often to beat. And then there's the squeezing or mechanical part that actually pushes the blood, and both of them need to be working. So in this situation, the electrical part is sending out the signal. The mechanical part has been damaged and cannot squeeze. Okay, it doesn't matter really, because they're still dead, right? I mean, all of these are dead. But what's important to realize is that in the middle one, the ventricular fibrillation, that's where we could really make a big difference in a patient's outcome by quickly getting there with an AED and using it. And I guess if you had to say the nice thing about cardiac arrest is that most patients who are in cardiac arrest are in ventricular fibrillation. Okay, and obviously the likelihood of a pediatric patient, a child or infant, going into cardiac arrest is minimal. So most of the times when we talk about cardiac arrest, we're talking about adults. Okay, and we're talking about older adults. Is it possible for a 20-year-old to go into cardiac arrest? Absolutely. I told you, about the guy in Shul and KJ. So it is possible. Okay, but if you talk about percentages, it's much more likely for somebody to go into cardiac arrest after the age of 50. Okay, and then again, more likely after 60 and more likely after 70. Okay, so if the test question said, in what rhythm and what type of cardiac arrest is an AED most likely to be beneficial, the answer would be ventricular fibrillation. Okay, if it says, what is ventricular fibrillation? It's an abnormal heart rhythm where the heart is no longer pumping, but it's shaking, it's quivering, okay, instead of squeezing and contracting. And again, an AED helps because when you put electricity through a muscle, it stops the muscle, so it stops the shaking and gives the pacemaker time to reset itself. I mean, you've all had a phone or a tablet or a computer that was not working properly, and your treatment for that situation was to shut it off and turn it back on, and then everything worked fine. Same thing in ventricular fibrillation. You're defibrillating them and shutting off the heart for a second, and then hopefully the pacemaker will take over again. The likelihood of that working and doing what it's supposed to do depends on how long the patient's been in cardiac arrest. So that's why, like I've been in Rockland County since 1988 as a paramedic. When I first got here, the police cars did not have AEDs. The cops had no interest. Actually, when I first got here, there really weren't AEDs, but whatever. The cops had no interest. There were no real AEDs or anything like that. And I would say our cardiac arrest success rate was not great, okay, survival rate. And then, AEDs came out, all the ambulances got them, the paramedics already had regular defibrillators, not AEDs. And again, there was no great increase in cardiac arrest survival because the ambulances had them. Because the ambulances back then were, voluntary ambulances. People were responding from home. There were no paid people. And it took a long time to get the ambulances. Then we decided to put AEDs in police cars. Okay, so in the beginning, it wasn't great because the older cops didn't really want to use them. We're going to get sued. We don't know what we're doing. We're cops. We're not EMTs. so they didn't really want to use them. As those guys started to retire out and we got the new guys and we started teaching them to use the AD right in the police academy when they were training to be police officers, it became second nature. And now all of a sudden you had cops racing to the scenes, using AEDs, shocking people within seconds of them going into cardiac arrest. And we'd get there and the patients would be like, what happened? And our cardiac arrest survival rate went way up. And it went way up because the speed of the first shock greatly increased by putting AEDs in police cars, because there's many more police cars on the road than there are ambulances, and they're not responding from buildings, they're right on the road. So in the hot solo world, where you have 100 vehicles, on the road equipped with AEDs, the success rate of cardiac arrest is higher, because in the non-hot solo world, right, you have an ambulance in a building and you don't have people taking their own vehicles to the scene. So it takes longer to get to someone who is, having an emergency. So that's, kind of what happens. The problem in the hot solo world is that you save the patient, but getting somebody to take the ambulance to the scene becomes a problem, because I guess if you call in and volunteer to drive the ambulance, you pretty much obligated yourself to go to the hospital. And that means now you're, out of service for a longer period of time. So the time I've spent in New Square listening to Dove at Dispatch and him trying to con people into actually taking the ambulance to the scene, I guess that's the problem. So they definitely get people to respond to the scene in their own vehicles. To get somebody to pick up the ambulance becomes the bigger problem. Okay, so VFib is also known as sudden cardiac death, right? So sudden death of the patient, because they have no idea that it's hitting them. Okay, it just hits them, boom, and it goes. Okay, we said the only thing that will stop VFib is defibrillation, okay, which is the shocking of the heart by using an AED. And that the AED is basically a device called a defibrillator. So there's manual defibrillators the paramedics have. They interpret the rhythm and they decide whether or not they need to do it. And then there's automatic external defibrillators, AEDs, okay, that have a ability to analyze the rhythm and make the decision for non-highly medical trained people, or actually non-medically trained people, because it's really designed for bystanders to use, and do it. In the beginning, there were AEDs that actually had screens on them, and there's still a couple out there. And we used to actually train in EMT class the EMTs to interpret rhythms, but really it became obsolete because of the fact that the machines were so good at it that we didn't need the EMTs to do secondary verification of the rhythms and stuff like that. So this should really be EKG. So I don't know, somehow I messed up the letters here, but it's not ECG, it's EKG. And then ECG is another way of saying it. Okay, so that's what an AED is. And you see it says external defibrillator. So patients who had a VFib cardiac arrest, ventricular fibrillation cardiac arrest, and were saved, a lot of times get what they call an implantable defibrillator in their chest. So they actually get a small machine implanted in their chest that monitors their rhythm. And if they ever go into VFib again, it shocks them internally to prevent them from dying. Most of the times it works. So you may know a family member who had a, cardiac arrest where they did not die. And it turned out that it was a VFib cardiac arrest, a ventricular fibrillation cardiac arrest. And then they had a procedure to insert that in there so that, if God forbid they go into VFib again, the machine, the internal machine will take care of it and they should never actually die again. Okay, now what's the downside of an AED? So an AED cannot tell, okay, if the patient actually is pushing out blood. It can only tell, so in other words, it's not analyzing, it's not feeling a pulse. So it can only tell if the patient needs to be shocked. So let's go back up here for a second. And let's pretend we put an AED on each one of these patients. So we put an AED on this patient, we let it analyze. It's going to say to us, no shock advised, check the patient for a pulse. Because it knows the patient's not in VFib, so it has no role. There's nothing you could do. Because if it shocks a patient who's in asystole, it's just going to ensure the patient stays in asystole, because again, an AED stops the heart, and in asystole, the heart is already stopped. Okay, so now think about what happens. You're a brand new EMT. You practice with the AED in class, and every time they had you practice with the AED in class, it told you to shock. Okay, now you're in real life, right? And you put this AED on the patient, it says no shock indicated. So you say, well, I guess they're not in cardiac arrest. Let me put them on their side and take them to the hospital. And you get to the hospital and they say, oh my God, you just transported this dead body to the hospital. The guy has no pulse. What could happen, what the downside of an AED is that sometimes people assume the AED knows everything. And if it's saying there's no shock indicated, that they think there's nothing they need to do but bring the patient to the hospital. Remember, the AD has no role in asystole and PEA. It only has a role in VFib. So if the AD says to you, no shock advised, check for a pulse, you need to check for a pulse. And if there is no pulse, you need to start CPR. Now, you're going to have a hard time finding a pulse on people in the beginning, on yourselves, on your classmates. If you have a cardiac arrest and you cannot find a pulse, even if you think maybe you feel something, you're not sure you feel something, start CPR. If they're dead, you're going to be helping them. If they just fainted, you're going to wake them up from the pain of the compressions. And then you're going to say, I saved you, even though you didn't. And you'll look like a hero. Okay, so never hesitate to start CPR if you're not 100% certain. If you have an unconscious patient, obviously if the guy's awake, he can't be in cardiac arrest. So if you have an unconscious patient and you're not 100% sure that you feel a pulse, start CPR. The worst you could do is be pressing on somebody's chest who's fainted, who's sleeping, right, who fainted, and you're going to wake them up, and don't worry about it. They're not going to do anything, okay? But if it is VFib, again, defibrillation will be the #1 life-saving thing. Again, in PEA, since there's nothing to shock, right, it's not a rhythm out of control, okay, it'll say no shock indicated, check for a pulse. Again, since during cardiac arrest, you will find no pulse, and you'll start CPR. Again, on a BLS level, that's all you can do. When the paramedics arrive or when you get them to the hospital, other things will be done for the patient. Okay, now where do we check for a pulse in a patient? So in a patient, we always try, like in an emergency serious situation, to find a pulse as close to the heart as possible. If it's not an emergency situation, in other words, if it's not a life or death situation, we usually feel for a pulse in the wrist, okay, by the hand. But in an emergency situation, we want to get a pulse as close to the heart because we would expect the pulse to be the strongest there and the most likely to be able to find. So in an adult, we look in the neck, what's called the carotid artery. Now you have a carotid artery on both sides of your neck. A test question will always be that you should check for the pulse on the side you are of the patient. Okay, so in other words, if you're on this side of the patient, you're not supposed to reach across and find it on the other side. In all honesty, it doesn't really matter, but it's always a test question that you feel for a pulse on the same side. What you don't want to do is ever on a patient is press on both sides of the neck on the same time, because you have 4 blood vessels bringing blood to the brain. You have 2 in the front and 2 in the back. If you push on both of the front blood vessels at the same time, you're cutting 50% of the blood going to the brain off. So we don't want to really do that. So you just feel on one side gently. Now, I'm going to tell you, it's going to take a while for you to feel comfortable with pulses. It's going to take a while for you to feel comfortable with blood pressures and all kinds of vital signs. So what you really have to do, okay, once you get your blood pressure cuff and stethoscopes, and we teach you how to check a pulse and everything like that, is you have to start annoying every family member you can get. Your fathers, your mothers, your brothers, your sisters, your wife, your kids, because you want to get good at checking for pulses on all ages of patients. So you don't want to just get your nice, healthy 14-year-old son who has a nice, strong pulse and check for a pulse on him. It'll make you feel good because you can find it nice and easy. But you also want to check for a pulse on your 90-year-old grandfather who maybe doesn't have such a strong pulse, so that you get good with all types of vital signs, okay? And the same thing like blood pressures. Now, what I will say to you is, until you know what you're doing, never tell anybody there's a problem, because more than likely there is no problem. You are the problem because you don't know what you're doing yet, right? So, you know, use family members, use classmates, use friends, whatever you have to get good with vital signs. The only way you're going to get good with checking with pulses, good with blood pressures, is do it repeat. It's a skill, and skills get better by repeating it time and time again. You're going to feel terrible in class. I can't do it. I can't hear it. I can't do this. You will by the end of class. Everybody by the end of class is able to do it. Okay. The instructors will show you tricks. They'll, you know, show you how to use your stethoscope the right way. Sometimes you put your stethoscope in the ear the wrong way, so it doesn't work. Sometimes you have the head of a stethoscope turned the wrong way and you don't hear it. So there's all little things. Don't get, you know, depressed. Don't get demoralized. Just ask for help. Like, if there's anything I could say to you, is you guys have spent money to be in class, okay? And, you know, you deserve a good education. Everybody who's in class to help you, you know, is dedicated doing this. So if you have any questions, you know, reach out and ask them. And trust me, if you're becoming annoying, I will be the first one to tell you you're becoming annoying. But, you know, or if you're asking questions without trying to read it yourself, I'll tell you that. But I don't want you to feel at any point that you're getting overwhelmed and you want to drop out of class because there's just too much stuff, okay? Because a lot of times it'll take 15 minutes and you'll feel better about it and feel and understand it better than spending 6 hours, you know, banging your head against the wall, getting more and more upset. Okay, so pulses in the neck, okay, called the carotid pulse. So, you know, again, if any of you printed this out, this would be something you want to underline because this is something you're going to hear a million times. And in kids, we check for a pulse in their upper arm called the brachial pulse. So I'm going to tell you that there's things I'm going to say to you because they're on the test, and I call them book learning, right? And then I'm going to tell you real life learning. So if any of you have little babies at home, try to feel the brachial pulse, and you're going to find it's a very, very difficult pulse to find. Okay, so the book is going to tell you to check it there. In real life, it's a very difficult pulse to find. The reason why is, what do you think the blood pressure in a little baby is? Very low, right? So as it is, the pulse is weak because the baby doesn't need to have a very strong pulse because there's a very small body. The other thing is that they have a short, fat, chubby arm, right? And you don't know what you're doing, and you tend to press hard. And since the blood pressure is low, you actually shut the pulse off, and then you think you don't find it, okay? Especially if you're a guy who does manual labor and you have some calluses, you know, if you have rough fingers, your sensation is weakened because you've been working with your hands, it's even going to be harder. So a lot of times when we do peds, I'll tell you, a lot of times what happens is the best thing to do is take your stethoscope and just listen to the baby's heart and make sure it's beating, because it's very hard to find a brachial pulse. The reason we don't look for a pulse in the neck in a baby is if you have a small baby at home and you look at their neck, their head almost sits on their chest. So there's not a lot of room to reach on a small baby and find a carotid pulse. So it is a little more challenging on a small baby. And, you know, anybody who's, you know, had a small baby, sometimes when they're sleeping, it's even hard to see if they're breathing, right? You know, your first baby, and you're staring at them in the crib and you're saying, like, are they breathing or not breathing? Because they're small. They don't breathe with a lot of effort. So you don't see their chest heaving like you would want to, especially if they have pajamas on. So when we do peds, we'll talk about it. Like, you know, let's picture, you know, you get called to somebody's house and they say their baby's not alive, and you walk through the door and you have to make a split-second decision. You know, God forbid, is this baby dead or is this baby just sleeping? And, you know, I'm just telling you now that it's hard to find a pulse. It's hard to see breathing, and everybody's looking at you like, you know, you're the person. You know, what do you got to do? You got to make a decision. So believe it or not, sometimes you give the baby a little pinch on the inside of their leg with nobody looking at you. And if the baby cries, what do? You take a deep breath and say, okay, the baby's not dead. Now I could try to figure out what's wrong. The baby doesn't cry. Now you have a problem, right? Now you say, I have to do a more thorough check. Is that, you know, baby alive or dead? And if you're not sure, you're just going to start CPR. And if the baby starts crying with CPR, you know they weren't really dead, and you move on from there. So, you know, everybody's going to have those first year of calls where they're not exactly sure what they're doing, and it can be very nerve-wracking. But again, no matter what you do, most of the times it's better than not doing anything. Just don't overtreat. In other words, don't do things that you don't know how to do, or don't do things that are above your level of training that you were trained in class. Okay.
One question. What was the word you said we should underline? I don't remember the word. What was it?
Carotid. It's the name for the pulse. So if you wanted to underline 2, okay, so over here, let's see. Okay, so adults and children, we check the carotid artery in the neck, and in infants, we check the brachial artery in the neck. Okay, just terms. Again, we're going to have a whole vocabulary. We're going to spend days on doing anatomy and physiology, which is how the body works and all the different parts of it and everything like that.
You mean the infancy meant on the hand? Not in the neck, right?
Hold on. What's that? Infant on the neck. I'm sorry, infant on the arm, upper arm.
Yeah,
Right here. Yeah, adults and child on the neck, infants on the upper arm. Okay, so let's just go through these terms and then we'll call it a night because it's getting a little late now. Okay.
Very blurry.
What's that?
It's very blurry, the screen.
It's very blurry?
Yes.
And the other screens weren't?
No, till now it was good.
Okay, let's give it a second. Hopefully it'll, well, you have this handout, don't you? I sent you this handout.
That's correct, yes.
Okay, so let's see, maybe hopefully, is it totally not readable?
And now it's getting better.
Okay, yeah, so it's just the internet speed, I guess. Okay, so let's go through some of these terminologies. So one-handed chest compressions. So most of the times when we do CPR on adults, we're using 2 hands. and again, they'll show you this on Sunday. A child, we're usually using the heel, what they call your dominant hand. Your dominant hand is if you're right-handed, it would be your right hand, left-handed. And the reason why, obviously, if it's a small child, you may not need the force of two hands to compress the chest to about 2 inches, right? Because that's the depth we said for children, about 2 inches, adult at least 2 inches, which means greater than 2 inches, and an infant about 1.5 inches, okay? When we do CPR in infants, okay, we have 2 ways that we could do it. Okay, we put 2 fingers on their chest, or we actually take our hands and put our fingers behind them and just have our thumbs on their chest. And again, they'll show you how to do that. So that's what those are. The AD we said was the automatic external defibrillator that we use to shock someone who's in ventricular fibrillation. The term agonal, okay, means very slow or almost dead type of stuff. So agonal gas means that when somebody goes into cardiac arrest, okay, the brain is the organ that controls breathing. The heart does not need the brain to tell it to beat because the heart has its own pacemaker. The rest of the body needs the brain to tell it to do something. So the lungs need the brain to tell it to breathe. Okay, when somebody first goes into cardiac arrest, a lot of times for the maybe 4 or 5 breaths, you know, they'll still try to breathe even though they're dead. And what will happen is they'll be very slow, exaggerated breaths, like types of breaths. So, you know, again, when people are new and inexperienced, they say the patient can't be in cardiac arrest because they're still breathing. But those are death breaths. Those are dying breaths. So we still treat the patient, okay, as if they're in cardiac arrest. An airway obstruction, we said, is that when somebody has a complete blockage of their airway so that no air is getting into their lungs, and we need to do something to free it up. And again, we'll learn the different techniques on Sunday. And how we know somebody has a complete airway obstruction is that they cannot talk. Okay, so if they're of the age of talking, we ask them if they can speak. Again, if it's a small infant that is not able to talk yet because they don't know how to talk, then it's totally our observation to decide. Okay, again, just terminology, apnea or apnic. Anytime there's a in front of a word in medicine, it means that it's not there. So apnea, okay, means a patient's not breathing. You're going to learn other terms as you go through class that have the PNEA or PENIC at the end of it, okay, and it's going to change the meaning. But apnea, okay, means not breathing. Like if you had DYS in front of it, dyspnea means trouble breathing. So there's different terms. Again, there was the prefix and the suffix type of thing, which, you know, some of you may have learned depending on what type of grade school you went to. Okay, so I'm going to scroll down a little bit. If it gets blurry, just give it a second, because I don't think the screen is refreshing as fast as on your side as my side. Okay, is it blurry?
Looking good now.
It's looking good. Okay, so arrhythmia, dysrhythmia. Okay, so rhythmia, rhythmia, like a rhythm, is a heart rhythm, right? When they say A, remember A in front of it means it's not there. DYS in front of it means it's not normal. So to complicate things even more, these 2 terms are used interchangeably, right? So they mean the same thing, even though they mean 2 different things. So what I'm trying to say is that when somebody speaks about this, 1 minute they'll say it's an arrhythmia, the next minute they'll say it's dysrhythmia, and they think it means the same thing. It means a non-normal rhythm. But technically the term arrhythmia means there is no rhythm. So that would be that asystole where it was flatline, where the dysrhythmia could be more like the VFib, the PEA, or a lot of other rhythms that people could be in where they're still alive, but they're not having a normal rhythm. Okay, so just to start introducing the terms, nobody's expected to, you know, be an expert on this or anything like that tonight, tomorrow night, the next night, or anything like that. But just to start, you know, doing the terms. Now, the pronunciation of the terms is going to be a little hard. Okay, but again, the more you say it, the more you practice it, you know, the better it gets. And you know, if you have access, well, obviously you all have access to the internet, but if you, you know, put in the term arrhythmia and then put the word of pronunciation or how to pronounce it after it, that the computer will actually, you know, pronounce the word for you, and that's how you kind of learn it. Now, aspiration was something that we talked about at the very beginning when we said sometimes a patient could have fainted, so they still have a pulse, but they're just not awake, and that we put them on their side. Remember we said lateral recumbent, left lateral recumbent, right lateral recumbent, to try to prevent them from getting food or vomit into their lungs. So the term aspiration is when that actually happens, that it goes into their lungs. And the problem is that if anything goes into your lungs besides air, it's not good, right? The lungs should only have air in them. That's their purpose. So if you get anything into your lungs other than that, it's not good, and you can get a pneumonia and an infection in your lungs. And a lot of times patients who go into cardiac arrest and we save them, okay, and we get them to the hospital and they have a pulse and they have a blood pressure, we find out later that they died from what's called aspiration pneumonia, which means that they, unfortunately, before we saved them, they vomited, and vomitus went down into their lungs. So the vomit went down into their lungs, and it caused a massive infection. It didn't kill them at the scene, but killed them days later. So that's why it's very, very important. And you'll learn on an EMT level how to use a suction machine to try to clear a patient's airway of anything that could go down into their lungs. Okay, so a systole, we said, was that abnormal rhythm where the heart just has no activity, it's flatline. Again, A in front of a word means it's not there. And systole, this other word, means a heart contracting. So asystole means the heart is not contracting, it's not pushing blood. A bag mask or bag valve mask device, or a lot of people just call it a BVM because it's easier to say, is a device that we use to force air into a patient who's not breathing so we don't have to put their mouth over it. Okay, basic life support is the term for a BLS ambulance, an EMT staffed ambulance that doesn't have a paramedic on it. And obviously an advanced life support ambulance would be an ambulance that has a paramedic on board. The brachial artery was the artery in the upper arm, which we have a brachial artery, but we said that in kids, the book tells us that's the better place to look. In real life, you'll find, like even now, if you try to find your own brachial pulse in your arm, you'll find it's a much harder pulse to find than the one in your wrist or the one in your neck. Brady means slow. Cardia means heart. So bradycardia means a slow heart rate, typically below 60. Okay. In your book, you're going to see that they have this term CAB. So years ago, the big term was ABC. In other words, when we assessed patients, we did airway, breathing, circulation. Now they decided that airway and breathing are less important than pumping, and that circulation, the pumping of the blood, is more important than making sure they have an airway to get air in and that they're actually breathing to get air in. So the way we assess them is that we always check for blood flow first and then breathing, okay? Cardiac arrest, we said, or sudden cardiac arrest, is the term for a person who's died and there is no cardiac output. There's nothing going. And we said there's three types. There's asystole, where the heart is flatlined. There's ventricular fibrillation, where the heart is shaking uncontrollably and we can defibrillate them to stop it. And then there's PEA, or pulseless electrical activity, where there's a normal rhythm on the monitor, but mechanically, so electrically the heart's working fine, mechanically there's no pumping action. Okay, the carotid artery is the pulse in the neck. Remember, there's one on each side. And we said that typically we try to palpate the carotid artery on the side of the patient we're on. You know, in other words, we're on the left side, we go for their, well, I guess if we're on the patient's left side, we go for the left carotid artery. And we never compress both at the same time. Chest compressions is the part of CPR where we're pushing, okay, on the chest, okay, to compress the chest. The term for the chest bone, the breastbone, is the sternum. Okay, so we're trying to compress the sternum down onto the heart, squeeze the heart between the breastbone and the spine, okay, the back. CPR, cardiopulmonary resuscitation, right, which is a combination of chest compressions and ventilation. Defibrillator is a machine that shocks the heart. An AED is a defibrillator that has a second part to it that analyzes the rhythm for you. Okay, so AEDs are used by EMTs. Defibrillators are used by other people who have more training. Okay, probably one of the next classes that's coming up is what we call medical legal, talking about legal aspects of what we do. So a DNR is a do not resuscitate order, which means that a patient has decided, or the family of a patient who's decided, okay, if the patient's not capable of making decisions for themselves anymore, that if they go into cardiac arrest, they do not want anything done for them. And that is a very common document that you will find in the field, except in the Jewish world. So in the Jewish world, you do not usually typically find DNRs. So most, you know, halakhically, you know, it's not a thing that's usually done. So, but in the non-Jewish world, we'll go on a call, the patient will be dead, and the family will say they didn't want anything done, and here is their DNR form, please don't do anything. And we don't do anything, we just let them go. We'll call the medical examiner's office and, you know, see if they'll release the body, and if they'll release the body, the funeral parlor comes and gets it. Okay, emergency response system is, again, your 911 system. We'll talk a little bit about communications throughout the class and how, communications works to help save lives. Okay, I wouldn't really too worry about gastric inflation too much, but gastric means stomach. And when we're ventilating somebody with the bag valve mask, if we're doing it with too much force, okay, we can get air in the stomach besides the lungs. And the reason why is that your throat, right, is a common connection between your lungs and your stomach. So at the very, when you're putting air down somebody's throat, right, that it can go either way. And we do things to maximize it going into the lungs. But if we're breathing too forcefully for a patient, if we're squeezing a bag valve mask with too much force, and we've already inflated the lungs fully, air will start going into the stomach. Now, if air goes into the stomach, what do you think happens? The patient then vomits, and then you have the risk of aspiration, right? So we'll talk about how we minimize that. The Heimlich Maneuver was named after a Dr. Heimlich, okay, a nice Jewish gentleman who invented the procedure for, dealing with somebody who's conscious and choking. He has died in the last couple of years, but fortunately he did not die of choking, because I thought that would have been a horrible way to go. The textbook would probably call it abdominal thrusts, because usually they don't like to give people credit for anything, so they just call it abdominal thrust. Standing abdominal thrusts is the procedure we do for somebody who's conscious and choking to try to get their airway clear. Okay, another medical term. So hypo, okay, it always means low, and hyper always means high. Okay, so hypo, okay, oxia, so a low oxygen, or the other way of saying is hypoxic. Okay, again, don't worry about it. You'll learn how to pronounce it. All these words will be second nature to you in a couple of weeks. Okay, so hypoxia means that the level of a person's oxygen, and we abbreviate oxygen as O2, okay, is low, and that could cause a bluish discolorization that you see around the lips, okay? And you've all seen this bluish discolorization around the lips from not hypoxia. You've seen it from the kids in the pool, and they got cold and their lips turned blue. The reason their lips turned blue when they were in the pool and got cold is that when you get cold, your body has a natural reflex where it doesn't allow blood to come to the surface, to the top of your body, because that's where the cold water is. So what it does is it keeps the blood deeper in your body. And since there's less blood getting to the skin that you could see, and the lips are the easiest place to see because the skin is thin there, the lips turn blue because there's less oxygen coming. But the patient's actually not having a breathing problem. They're just really having a cold problem. But when somebody's in respiratory distress, somebody's having trouble breathing, and there's no cold involved, and we see their lips turning blue, we know that their level of oxygen in their body is very low. Okay, mouth-to-mouth breathing is when we do not use the bag valve mask to breathe for someone who's not breathing, and that's also called artificial respirations. Okay, and again, real life-wise, we do not put our mouths on people that we do not know. Okay, public access defibrillation, or PAD, is the legal term for a law that allows people with no medical training to use an AED to help other people and and have no risk of being sued. Okay, so, and again, that's because AEDs cannot hurt a patient. If we were to put an AED on a sleeping patient, put the pads on them, turn it on, the whole 9 yards, all the machine would say is no shock indicated, because they're not in ventricular fibrillation, they're sleeping. And the only pain we would cause them is when we're peeling the pads off their hairy chest and taking all the hair off. So, you can't hurt somebody with an AED. You could hurt your partner if you're shocking a patient who is in cardiac arrest, who is in VFib, and you don't pay attention to whether or not they're touching the patient. But you can't actually hurt a sleeping patient or somebody who doesn't need to be shocked with an AED, so you don't have to fear using it. A pocket face mask is another piece of equipment you will get, which is a barrier device between your mouth and the patient's mouth if you choose to do mouth-to-mouth. So in other words, it's a way of ventilating somebody using your breathing without using the bag valve mask to squeeze air into them, but there's a barrier between you and the patient's mouth. Okay, again, rescue breathing is the same as artificial ventilation, which is to breathe for someone who is not breathing on their own. Respiratory arrest is the, part of, say, cardiac arrest, or it could be separate of cardiac arrest. Arrest always means it's not happening. So cardiac arrest means no heartbeat, no breathing. Respiratory arrest means they do have a heartbeat, but they are not breathing. Now, the problem is that if you don't breathe for them, the heart will stop eventually within minutes because it's not getting the oxygen it needs. It's oxygen and sugar are the fuel that the body needs. The heart needs oxygen and sugar to continue beating. Syncope, we said, is the medical term for fainting. And we said there's lots of different reasons why people have syncopized. You may have come out of a hot mikveh and felt dizzy. And you've even heard people who fainted while they're in the mikveh. So what's the problem? Like, why is the mikveh causing people to have syncope? So hot water, okay, when you immerse your body in hot water and you raise the heat, your blood vessels relax and open up and get bigger. So, you know, obviously you have the same amount of blood that you started with before you went into mikveh. But if you open up your blood vessels, increase their diameter, increase how big they are, your blood pressure drops because you didn't gain any more blood. So if your blood pressure drops, you're not getting enough blood to your brain. And if you're not getting enough blood to your brain, you feel dizzy and you may even faint. Or let's say you were sound asleep. You were exhausted, you went to sleep. 3 o'clock in the morning, your kid starts screaming. You jump up to see what's going on. And all of a sudden you feel all weak and dizzy. Well, while you were sleeping, your heart rate was the slowest it was all day. Your blood pressure was the lowest it was all day because, you know, you're not doing anything. And now you suddenly jump up and you're standing and your heart and your body has not reacted to that yet. And you're not getting enough blood to your brain because you went from a relaxed standpoint laying down to an active standpoint standing up, and your body didn't compensate or get used to it yet, and people faint, right? So, you know, that's just different reasons why. I mean, obviously you could be vomiting and lose fluid and faint. You could have been scared and have like a psychiatric, psychological reaction to somebody and faint. So there's a lot of different reasons why people faint. And we'll, you know, we'll go through all that and talk about it. And sometimes we don't know. You know, sometimes people say, I fainted, you got there, they're talking to you, everything's fine. And the whole room is saying, yes, they fainted, they were unconscious, but there's nothing that you find on your examination. And those patients will then be sent home. They'll go to the hospital, get checked. If they don't find anything, they'll be sent home on an EKG machine they wear on their chest for a week. And the machine stores the EKG, and then they have people that the computers that actually analyze it to see if they've went into an abnormal rhythm. There's people that go home on an automatic blood pressure cuff that takes their blood pressure every 15 minutes, you know, throughout the day, and see maybe their blood pressure went low. So, you know, sometimes it requires weeks of testing to figure out why somebody faints. So ventricular fibrillation, where we said the abbreviation is VFib, is when the heart, the pacemaker of the heart goes out of rhythm. And instead of it being sending impulses out at a normal interval, it's sending thousands of impulses, and the heart, instead of contracting and squeezing out blood, just shakes and goes out of control. And ventricular tachycardia is a similar thing, just it doesn't have to, in ventricular tachycardia, mean the patient went into cardiac arrest. It's not good. They're not going to feel good, okay? But it would be a situation, either they're dead or they look horrible, and when you go to feel for a pulse for them, you find it to be very, very fast and very weak. And again, since you don't have an EKG monitor, you're not going to know they're in VTAC. But when the paramedics arrive and put them on the monitor, you're going to notice the paramedics get very excited and very nervous and start running around doing a lot of things, because this is a rhythm that can lead to somebody going into VFib. So if they could be dead from it, but they could be alive. And now every, you know, minute matters of what the paramedics do and how quick they get medicines on board to prevent the patient from going into VFib. And the last thing we'll finish up with is the universal sign of choking, the universal choking sign or sign of choking. Okay, there's usually a test question. They say, what does a patient do to signal when they're choking? And they say that they bring their hands to their neck like this. So again, there's things I'm going to teach you. They're in the book, and there's real life things. I have to tell you, you've all almost choked on a piece of food, or maybe some of you have choked on a piece of food, or you've witnessed somebody almost choke on a piece of food. Okay, so most people who are choking and do not have a complete airway obstruction are coughing like crazy, and they're not grabbing their neck, right? They have their hands on the table, they're trying to support themselves, and they're coughing like crazy. People who are choking, have a complete airway obstruction, believe it or not, typically sit quietly and do nothing until they realize they cannot clear that obstruction. And then they jump up, and then they may put their hands around their neck. But for the first couple of seconds, they actually tend to sit quiet and try to kind of analyze what's happening, and they actually try to swallow and see if they can clear their own airway. So to think that every person who's choking is going to slap you in the head and grab their neck and start pointing to their neck and stuff like that, that doesn't often happen, okay? But on the test, the universal sign of choking is when somebody brings their hands to their neck like that. Okay, so does anybody have any questions on anything we went over tonight? Okay. Anything? Okay, so what I would say is, if you have your textbook, try to find a chapter that deals with CPR. I think it's an appendix in the back. I don't think it's one of the earlier chapters, but try to find a chapter that deals with CPR. If you have time between now and Sunday, okay, I know there's not a lot of time, you know, review what you could review. I gave you a couple sheets that list all the numbers and everything like that. So try to look those over and, you know, get the numbers down pat. And, you know, David and Yankee, and I'm sure there'll be, you know, another instructor or two on Sunday. We'll go over all the skills. Again, please, social distancing, masks, and everything like that. I'm not quite sure how David and Yankee are going to work out CPR with masks on, but that's their problem. I don't have to worry about that. So we'll figure out how to do that. And, you know, hopefully at some point I look forward to seeing you all in person, and that we'll be in a post-COVID state and stuff like that. In the meantime, tomorrow I will send you my phone numbers. I will also send you a link. Well, I'll send you actually a bunch of links. One is that I have a Dropbox account that has tons and tons of pre-recorded lectures and everything like that on it. I wouldn't get too far ahead, you know, and stuff like that, unless you already have a little bit of a medical background. But that's all stuff that you're, you know, feel free to, whenever you want, to look at and play with and stuff like that. You do not need to pay for your own Dropbox account. You can make a free Dropbox account. The only difference would be is you're not going to be able to download that much stuff from my account to your account if you have a free one, because it limits you, I think, to a couple megabytes. But again, you know, you could put something in there and then look at it and delete it and put something else down there. Some of you may already have a Dropbox account. In that case, you know, you can move the whole thing over. But there's a ton of stuff there. And, you know, like I said, just if you have any questions, anything, reach out to me. I'll try to help you as best I can. My day starts early and ends early. So I am in bed usually, you know, if it's not a night like this, I'm usually in bed by 10. So if you are kind of guy who wakes up late and stays up late, you know, that's not me. I wake up early and go to bed early. So don't bother me, you know, typically, you know, after 7, 8 o'clock at night, because I'm either with my family or getting ready for bed. But in the morning, it's fine, you know, to reach out to me. And again, if I'm busy, I'll just text you back and say I'm busy. I'll get back to you. If I don't get back to you, which is rare, then feel free to remind me, you know, and I might have forgotten or something like that. And like I said, David and Yankee are also available to help. And, you know, I hope we have a great class and we have some fun together and learn a lot of stuff. And hopefully a year from now, you'll be emailing me, telling me all the lives you saved. Okay. So everybody have a good night. Have a good Shabbos, and we'll talk again. I don't remember when the next class is, but we'll be talking again soon. Okay?
Thank you. Have a good
Take
night.
care.
Good night, thank you.
You're welcome. Be well.
Chapter 18.
Chapter 18? Okay.
And the book.
Okay, thank you. Good night.
Great, thank you.